Welcome. In this lecture, we'll be discussing dementia. Dementia is a chronic and progressive decline in cognitive function that interferes with a person's ability to perform daily activities and maintain independence. Dementia does not affect the level of consciousness. Instead, it involves impairment in at least one cognitive domain: memory, language, executive function, attention, or visual spatial skills. Dementia classically affects memory. A mnemonic I use to help remind myself of this is with the word dementia, where the MEM helps to remind me that it affects memory. The initial workup for dementia is to first rule out reversible causes. Both hypothyroidism and vitamin B12 deficiency can mimic dementia by causing memory problems, confusion, and slowed thinking. We typically get a TSH level to look for hypothyroidism and a vitamin B12 level and treat as needed. Another common cause is actually depression, especially in older adults, as this can present as pseudodementia. This is why individuals who have memory issues are classically screened for depression. Furthermore, for other causes, we can get a CBC to look for anemia, CMP to look for electrolyte issues. In chronic alcoholics, we typically get a folate level, as well as syphilis. But by far and away, the three most common causes of reversible dementia are these three. Let's go into a little bit more detail about pseudodementia. Pseudodementia is a condition where depression, classically, or another psychiatric illness causes cognitive symptoms, such as memory loss, poor concentration, and this can mimic dementia. But, unlike dementia, this is classically reversible. As we can see, pseudodementia is classically caused by depression, and will be a sudden or acute change in mentation, where comparatively to true dementia, this is more gradual or progressive. It takes longer for symptoms to really manifest. People with pseudodementia are classically aware of their memory issues and are worried about it, where individuals with true dementia are classically unaware of any change in mentation. Pseudodementia is reversible classically by starting an individual on SSRIs for treatment of depression, where true dementia is usually irreversible. Another thing that we may see during questioning is individuals with pseudodementia, aka depression, will typically answer "I don't know," showing lack of interest in conversation, where individuals with true dementia will typically guess at the answers that are asked of them. Pseudodementia, comparatively to true dementia, is high yield to know for exam day. Now, going back to the initial workup, we also need to undergo some form of cognitive testing. We can either do the MMSE, the Mini Mental State Examination, or the Montreal Cognitive Assessment, aka the MoCA. The MMSE focuses on orientation, recall, language, and basic visual spatial skills. It's quick, roughly only 5 minutes, and is usually scored out of 30. It is widely used, but less sensitive for detecting mild cognitive impairment. A score of less than 24 out of 30 suggests mild cognitive impairment. On the other hand, the MoCA, which is also scored out of 30, typically includes executive function, delayed recall, and more complex visual spatial tasks, making it more sensitive than MMSE for early cognitive decline. A score of less than 26 out of 30 suggests some form of mild cognitive impairment. Furthermore, all patients with suspected dementia should get imaging at least once. This is to rule out treatable or structural causes. This can either be done with a CT, but preferably an MRI of the brain. In some select cases, we can also get an EEG to look for seizures or subclinical seizures, which may be causing changes in mentation. The rest of this video will cover the most common and most tested causes of dementia. Beginning first with Alzheimer's dementia. Alzheimer's dementia is believed to be caused by a buildup of toxic proteins that damage the neurons, both inside as well as outside. Now, the classic findings can be broken down either into micro findings or macro findings. We'll first talk about the micro findings. This can be beta-amyloid plaques, which are formed from abnormal cleavage of the amyloid precursor protein, aka the APP. This accumulates outside of the neuron and disrupts cell-to-cell communication and triggers inflammation. This is a classic image that demonstrates what beta-amyloid proteins look like. Neurofibrillary tangles are actually hyperphosphorylated tau proteins, and this accumulates inside of the neurons. This disrupts microtubules and leads to cell death. Classically, on microimaging, they look like little flames, and something that you must be aware of for examination day. We also may see a cholinergic deficit. This is due to a decrease in the neurotransmitter acetylcholine, which is important for memory and learning. This is thought to be due to a low choline transferase enzyme, also known as CHAT. Macroscopically, or grossly, we may also see brain atrophy, especially in the bilateral temporal areas as well as the hippocampal areas, which should make sense as the hippocampus is important for forming memories. We may also see, due to accumulation of the beta-amyloid plaques, something known as cerebral amyloid angiopathy, aka CAA. This is high yield to know for examinations, as CAA is a very common cause, especially in the elderly, of hemorrhagic stroke or intracerebral hemorrhage. Now, Alzheimer's dementia overall is the number one cause of dementia, and it has a multitude of different risk factors. Classic risk factors associated with every type of dementia will be age, as an individual gets older, you're at higher risk, as well as female sex. The rest are mostly based around mutations. Down syndrome increases your risk for Alzheimer's dementia, as the extra copy of chromosome 21 increases the gene dose of the APP gene that we talked about, leading to excessive buildup of beta-amyloid production. Other mutations can be the APOE4 allele. This variant of the apolipoprotein E gene impairs clearance of the beta-amyloid protein from the brain, leading to an increased risk of Alzheimer's dementia. Of note, the other type of the allele, APOE2, is actually protective. So if you have this, you have a lower risk of Alzheimer's dementia. And then, of course, you also have the presenilin genes, the 1 and 2 mutations. These genes encode parts of the gamma secretase complex. This cleaves or breaks apart APP. And these mutations cause an abnormal processing, leading to increase of the beta-amyloid plaques. Thus, in summary, all of these mutations, besides the APOE2, increases beta-amyloid plaques. A mnemonic I use to help remind myself of this is 4 evil, 2 protect, and 1 cut. And what this means is that APOE4 is evil as it increases your risk for Alzheimer's dementia. APO2 protects as it decreases your risk. And then, of course, the presenilins 1 and 2 cut. It cleaves or cuts the APP and increases the amount of beta-amyloid plaques and thus increases your risk for Alzheimer's dementia. The Alzheimer's presentation is very classic, as we have early and late onset symptoms. Usually, we get some form of memory loss. Typically, this is antegrated memory, meaning that long-term memories are fine, although you begin to forget new things. You can't form new memories. So you forget where you place your keys, new people you meet, or maybe conversations you just had. You can also have visual spatial skills, such as getting lost in one's own neighborhood. Language difficulties, such as difficulty finding words, and of course, personality changes, as individuals with Alzheimer's dementia are at increased risk for irritability, apathy, and mood swings. They are also at increased risk, and early on, they may start demonstrating signs of social isolation, which drastically increases your risk for depression, which is also seen in Alzheimer's dementia. Late symptoms may be symptoms such as hallucinations. Urinary incontinence is classic and usually seen late in the course, as well as motor issues. Alzheimer's dementia is usually diagnosed clinically, as we first must rule out the reversible causes of dementia, and we must get a cognitive testing. For definitive diagnoses, although this is rarely done but sometimes asked of you on your exams, you must do this via postpartum with a brain biopsy. In some cases, imaging can be helpful. Imaging such as the MRI of the brain, where you see something known as hydrocephalus ex vacui. This is a form of compensatory ventricular enlargement that occurs due to loss of brain tissue, not due to increased CSF. So we can see this here. We can see that we have hydrocephalus, or extreme CSF amount of enlarged ventricles. This is due to, because the brain shrinks, the brain tissue shrinks, the ventricles passively enlarge to fill the empty space. The CSF pressure is normal, unlike in other forms of hydrocephalus, but this is classic for Alzheimer's dementia. We may also see atrophy, again, in the temporal lobes more so than anywhere else, and this leads to destruction of the basal nucleus of minor. And this is important because this nucleus helps to produce acetylcholine, which is one of the main issues we see with the pathogenesis. Now, treatment for Alzheimer's dementia is typically with cholinesterase inhibitors. This leads to an increased amount of acetylcholine, something that we are deficient in. This is used more so as first-line medication in mild to moderate Alzheimer's early on in the course. This is donepezil, rivaroxaban, and galantamine. Later on in the course, with moderate to severe forms of Alzheimer's dementia, we may use a medication known as memantine, which is an NMD antagonist. Now, this does not replace the first line, but instead we typically add these on. The next dementia we'll talk about is vascular dementia. This is due to some form of cerebrovascular disease. This is the second most common cause of dementia behind Alzheimer's. Typically, these individuals will have some history of stroke with multiple other risk factors, such as smoking, obesity, sedentary lifestyle, hypertension, hyperlipidemia, etc. They will classically present with stepwise decline. And what that means is that they'll have some form of event, such as a stroke, and then you'll get new memory deficits, new progressive deficits. You will stay that way until you have another event, such as another stroke or another TIA, and then you'll form new deficits, and the cycle will continue. As with each event, your memory will get worse and worse. Classically, the first thing that happens is you typically get impaired executive function, as this is the most prominent symptom. An example of this is you have trouble making decisions. Now, vascular dementia is typically diagnosed clinically with the MRI of the brain being supportive, as this helps to find ischemic events. Treatment is you first try to treat the underlying risk factors, such as the hypertension, hyperlipidemia, diabetes, etc. You may want to start these individuals on aspirin and statins to prevent reoccurrence of strokes, and in some rare cases, acetylcholinesterase inhibitors may be used, although there is limited evidence for this benefit. The next dementia we'll talk about is frontotemporal dementia. This is a progressive degeneration of the frontal and usually the temporal lobes. This is due to accumulation of two abnormal proteins. Hyperphosphorylated tau, in this case these are known as PIC bodies, which can be demonstrated here. These brown-like deposits are known as PIC bodies, and or TDP43. Tau is normally involved in stabilizing microtubules, but in frontotemporal dementia, it actually misfolds and forms tangles inside the neurons. TDP43 is a protein that helps regulate RNA. This becomes mislocalized and forms toxic clumps in the cytoplasm. These protein accumulations lead to brain cell death, especially in the frontal and temporal lobes. Now, the presentation for FTD has based around the variants. There are three main variants: behavioral, semantic, and aphasic. But by far and away, the most common variant, and the one that you're most likely to be tested on, is known as behavioral. Behavioral is by far the highest yield, and has something known as Clover-Bucy syndrome. This is when individuals become hyperfixated orally. They become hyperorality, hypersexuality, and hyperphagia. They like to put things in and around their mouth. This is due to cause of the bilateral amygdala, typically due to association with atrophy of the temporal lobes. We may also see compulsiveness or apathy, very similar to what you may see in Alzheimer's disease. And dementia typically presents later in the course, as we typically get these personality changes first. Frontotemporal dementia is typically diagnosed clinically, although MRI of the brain may show atrophy of the frontal and temporal lobes. Here's an example of a normal brain, and on the right here we see atrophy of both the frontal as well as temporal lobes. The treatment for FTD is typically supportive, as no medications has been shown to be disease modifying. The treatment is usually based around the symptoms. Example being for behavioral symptoms, we may start them on SSRIs. For Lewy body dementia, this is due to an accumulation of something known as alpha-synuclein proteins. Alpha-synuclein proteins form something known as Lewy bodies. This is due to misfolding in aggregates. As we can see, Lewy bodies are also described as eosinophilic cytoplasmic inclusions, and this is what Lewy bodies look like. These little brown deposits, these are eosinophilic inclusions occurring. These are toxic intracytoplasmic inclusions. This leads to cell death, particularly affecting the cortex and subcortical areas, like the substantia nigra. This goes on to demonstrate the classic presentation. We usually see a triad. The triad will typically be hallucinations, usually visual, as we can remember this with hallucinations, Parkinsonism, and dementia. You should always see some form of cognitive issue before Parkinsonism changes. This is also highly associated with REM sleep disturbances, as REM sleep disturbances are associated with alpha-synuclein protein. Some of these REM sleep disturbances may demonstrate dream enactment, as an individual may act out their dreams while sleeping. Another high-yield testing point is you may see something known as antipsychotic sensitivity, as giving an antipsychotic in these individuals, who would maybe be given this medication for their hallucinations, tend to actually make their symptoms worse. Lewy body dementia is classically diagnosed clinically, and the treatment is acetylcholinesterase inhibitors, very similar to Alzheimer's disease, as this may help with cognition, attention, and hallucinations. Creutzfeldt-Jakob disease, also known as CJD, is actually caused from a misfolded prion protein. This is when PRPC folds into PRPSC. This leads to a misfolded chain reaction. These abnormal prions accumulate in the brain, leading to neuronal death, spongiform changes, and rapid neurodegeneration. Simply put, this converts an alpha helix to beta sheets, and this rapidly progresses extremely fast. This can either be a sporadic mutation, familial, so it is passed down from generation to generation, or in some rare cases, it can be acquired. The most common surgery it's acquired with is through cataract surgery. It can, in some rare cases, be due to consumption, hence the name Mads cow's disease. Now, like FTD, the presentation of CJD has 5 known subtypes. The most common is known of CJD, so the most common subtype of all the prion disease is known as CJD. This typically presents with rapidly progressive dementia, occurring within weeks to months. You also may see startle myoclonus, so rapid movement of one limb or one part of the brain, typically when an individual is startled, as well as ataxia if these individuals are able to walk. Now, there are some things that can push us in the right direction for diagnosing CJD. Typically in the MRI brain, you may see something known as cortical ribboning. This is what cortical ribboning looks like, as you kind of see in all these sulci where the outer portion of the gyrus are, you kind of have these bright hyperintense deposits. Looks like ribbons. You may also see hyperintensity of the caudate or the putamen. On EEG findings, you classically see triphasic sharp waves. This is not specific for CJD, as this is more so seen in metabolic encephalopathy in general. And on LP, you may see the presence of something known as protein 1433. This is a normal cellular protein which is involved in regulating many cell functions, but in the context of CJD, its presence in the CSF is used as a diagnostic marker. It is due to the massive neuronal death which causes 1433 proteins to leak into the CSF. So the diagnosis, gold standard for CJD, is biopsy, typically done post-mortem. In this biopsy, you will typically see spongiform something known as spongiform encephalopathy or vacuolization. As you can see, there's all these areas of destroyed neuronal tissue, which looks like it's just cheese-like or Swiss cheese-like. The treatment of CJD is typically supportive, as the average life expectancy in the normal form of CJD is only 6 months, and in one of the variant forms, it's actually only 12 to 14 months. All these individuals sadly will pass away very rapidly. The last topic that we'll talk about is delirium, as this classically affects 10 to 30% of hospitalized patients. This will present as a transient change of consciousness with waxing and waning symptoms. These symptoms can be disorientation, tremor, dysphagia, but you classically also see hallucinations or psychosis. This is not a permanent change, but this is rapid on onset, so it's different than dementia. This is usually worse at night or early in the morning. Something that they like to test on examinations is if the patient has a history of dementia, Alzheimer's, FTD, any form of dementia, and they get this presentation, classically at night when the sun goes down. This is known as sundowning, which is slightly different than delirium. Anyone can get delirium. You technically don't have a history of dementia, but if you do, it is known as sundowning. The treatment for delirium is typically supportive, with reorientation, well-lit rooms, and a quiet environment during the day, and then making it the opposite, dark at night. If there are signs of psychosis or the patient is aggressive, haloperidol is typically our first line of defense, and it has definitely high yield for exam day. Here is a table summarizing what we've discussed in this lecture, and that concludes this lecture on dementia.